Afternoon, everyone. I'm presenting a case titled Football. Football can be a dangerous sport. Start with my presentation. So the case is of a young boy, 15 years old, HIV negative, previously well, who presented at one of our satellite hospitals at the beginning of around mid-May. His pastime, usually in his pastime, he plays social soccer after school in the open spaces in the township. He had presented to hospital with a 5-day history of abdominal pain and lower back pain. At this time, during this time, he had visited a traditional healer after the onset of these symptoms, given some herbal medications. They did put in some traditional marks on his feet. He did not improve. Later on, presented to hospital with the above symptoms. When he was assessed by the general surgeons, who assessed him as an acute abdomen, they thought that.
Sorry, Thomas, to stop you, but we're not seeing your screen. We're just seeing you with the screen behind. Can we just try and share screen again, please? It is on multiple partners, so you should be able to do this. Yep, that's great. And then just full screen. Brilliant. So that's presenter mode still.
Okay, well, on the desktop. Can you see the full screen now?
Yes, yes.
Yep, lovely.
Apologies for that. So I think I was at the point where he was assessed by the surgeons. We evaluated him at the receiving hospital, assessed him as an acute abdomen with the initial thought of appendicitis or a peritonitis. They did a laparoscopic appendicectomy where the surgeons noted that the appendix was fairly normal. There were no suggestive findings of appendicitis or peritonitis in the abdomen. Post-operatively, he did not do so well. He complained of pain everywhere, as he said. And from their assessment, they thought it was clearly out of proportion with the clinical findings that were there. They also noted that at this time he had these intermittent episodes of spasms and hypertonia. So 3 days into the admission, his condition, his medical condition became worse. He went into type 1 respiratory failure with the thought that he might have aspirated. So he was intubated at this time and transferred to ICU at Muza Hospital. When the consult for ID was made, when he had arrived at the ICU. So we did take another history. We noted that there was indeed a history of spasms, which were generalized, clenched teeth on light touch from history from the surgeons as well. We dug a little bit back. There was an unclear childhood vaccination history, and there were no reported recent injuries to him. He was not on any other medications prior to his current admission. He had not taken any neuroleptic agents, things like metoclopramide, and he did not use any illicit substances. So on examination, when we saw him, he was intubated. He had a GCS score of 8T over 15. He was pyrexia and tachycardic. Examination of the mouth and teeth, mouth revealed normal dentition. And neurologically, we noted trismus, which was quite evident. And we did see some generalized spasms with agitation. He became easily agitated on light touch and on any minimal amount of auditory stimulation. His cranial nerves were quite intact with no pupils being symmetrical on examination. On the extremities, we noted these small scarification marks made by the traditional healer we first presented to, and we noted some old abrasion marks on the legs as well. Careful examination of the feet, since from the history we noted we had indicated that he's a football player. He likes playing soccer, usually in the dusty streets of the township. So we did a careful foot examination. We noted a small fluctuant. We thought it could be probably an abscess on one of his toes. Workup done during the ICU admission. When he presented, he had a white cell count of 10, and during the course of his stay, he didn't really go up. On the last day we saw him, it was at 20. They also did a creatinine kinase. Because of the spasms, there was a worry of rhabdomyolysis. Initially, it was quite elevated at 48,000, gradually coming down to 1,341. His syphilis screen was negative. Blood cultures remained negative throughout the course of his stay. Tracheal aspirate, which was done on admission. During the course of his admission, later grew some staph aureus, which was sensitive to cloxacillin and erythromycin. Chest X-rays done on admission, they showed right mid-zone infiltrates, which later cleared on the successive imaging, maybe probably lending further supporting the initial evaluation of aspiration in movement. So at this point, we made a clinical diagnosis of tetanus, clearly complicated by hypoxic injury and possibly aspiration pneumonitis with autonomic instability based on some of the other vitals that we had at this point. So during the course of his intensive care unit stay, he received supportive care. He continued to be intubated, and in anticipation of a prolonged stay, tracheostomy was eventually done during the course of this stay. He was maintained on sedation for morphine and propofol. Also, he got some diazepam to help with the spasms. Initially, quite a low dose of 20 milligrams per hour to quite a high industrial doses of 150 milligrams per hour, showing how severe his illness was. We also got some magnesium sulfate initially to prevent seizures as well. We suggested that they nurse him in a closed environment with minimum contact, partially closed curtains, and also not to with the light switched off. Sorry. Directed treatment that we suggested at this point was metronidazole and tetanus immunoglobulin, and eventual debridement at the base of the right toe to help with source control. This was eventually done during the course of the stay, and some minimal pass was noted for the wound. So I will just briefly talk about tetanus, its etiology, epidemiology, and some clinical features that are associated with tetanus. It's caused by an anaerobic gram-positive spore-forming rod, which readily survives in the environment. Entry is via abrasions, puncture wounds, and in neonates and vaccinated mothers through the umbilical stump. So usually there are about 300 cases of neonatal tetanus actually reported each year in South Africa. And it's usually in those areas which are rural and economically deprived. Maybe they do not have good access to immunization. Globally, there are about 38,000 people died from tetanus. That was in 2017, and you can clearly see from the distribution of the map some of the new infections which occur in tetanus, in particular, looking at Africa. I think India is one of the leading prevalences as well. So, fatal cases occur in about 11% of reported cases. I must add that there's no comprehensive data on the epidemiology, so some cases may not be reported. It might be actually an underestimate of what is clearly happening on the ground. So on the clinical features, usually they, when you're taking the history, there might be a history of under-immunization. It could be the mother who didn't, during the pregnancy period, didn't get immunized, properly immunized. And there might be also history or evidence of injury. Christmas, Dr. John is also evident on clinical examination. And usually these patients have generalized muscle rigidity depending on the type of tetanus that they have. They also get spasms and abdominal rigidity. Respiratory distress is also another complication that might happen, as well as dysphagia. Due to the pathophysiologic process, as my colleague mentioned later on, there is some autonomic dysfunction which happens, causing variability in blood pressures, sympathetic symptoms becoming more prominent. So in tetanus, there are more or less 4 types of tetanus. Generalized form, which is the commonest form, which is readily seen. I think that one can also be graded from grade 1 to grade 3. Grade 1 being the mildly severe, and grade 3 being the most severe form associated with dysphagia, respiratory distress, and these kind of things. The cephalic form is usually associated with cranial injuries. People might also have infections, middle ear infections. So patients usually present with cranial nerve pulses as well. The localized forms, you get spasms in a particular part of the body. Might be also related to injury in that specific part, but sometimes generally involves to the general form as well. Neonatal form actually the commonest form of tetanus seen in children with under-immunized mothers, also associated with traditional practices where some dates sometimes might be applied around the umbilical staff. So entry for the neonatal form of tetanus is usually through the neonatal staff, and the disease occurs in the first 28 days of life. So some of the differentials that one might need to consider when considering tetanus, malignant neuroleptic syndrome is one form, is one differential. Strychnine poisoning also, it's a great poison that is commonly used. Tetanus might also be confused with a seizure disorder. I think as the disease evolves, patients might also eventually complicate with seizures as well. Dystonic drug reactions might also it's also another important differential. So good drug history is important to consider when one is evaluating a patient suspected of tetanus. So in our case, acute abdomen was the major differential. As the patient that presented with abdominal rigidity, initially the patient that actually presented with neck pain, and what they thought was abdominal rigidity, secondary to peritonitis. of this, there are several papers which have been written, similar presentations. Take one, I think, one of the references that I referenced, 47-year-old in Singapore. I think it's a paper which was published in the Singapore Medical Journal in 1994, written by Cham in where a 47-year-old gentleman presented to the hospital with no abdominal pain, and on examination with those abdominal rigidity, they thought he had an acute abdomen, managed as an acute abdomen, continued his clinical condition didn't actually improve after the operation, eventually needing intubation in the ICU care. Then they later on went back retrospectively to the good history, established that actually he had puncture wound lesions occurred a month earlier, and eventually made a diagnosis of tetanus. So my colleague will take the other side of this.
Okay, thank you, Thomas. It's Lucas here. I was asked to go to a recent paper discussing current treatment paradigms for tetanus. So I will be doing that. And before we get there, I wanted to quickly take you through the basics of the pathophysiology, because it's important to understand how the treatment basically works. So basically, when a wound occurs and gets infected, spores of Clostridium tetani enter the wound. Under anaerobic conditions, which may be present in wounds such as this, these spores can then germinate and multiply locally as bacilla. And rather than creating like a primary, like sort of bacteremia where the bacilli actually promulgate through the body, what actually happens is that the bacilli produce a toxin called tetanus toxin or tetanus spasm locally. And that toxin actually produces all the effects that are linked to the disease. So what happens when tetanus spasm is created inside the wound is that this toxin actually enters axons at the neuromuscular junction close to the wound site. They basically get endocytosed at that point. And basically, the toxin hijacks a retrograde axon of transport mechanism that is used to transport all kinds of molecules through the neuron to basically retrograde transport up to the neuronal body located in the anterior horn of the spinal column. When they arrive there, they are then released into the synapse, and this is the synapse between the excitatory motor neuron and the interneuron. And it is then transcytosed, so again taken up by this inhibitory interneuron. If we kind of go back to like med school, then if we sort of think about what the functions of those interneurons are, basically those interneurons in the spinal cord exist to dampen certain skeletal reflexes and excitatory motor potentials. And usually you use the neurotransmitter GABA to achieve this. So what happens is once the toxin enters the presynaptic, is in the synaptic cleft, enters the presynaptic axon of the interneuron, the toxin then continues to interfere with the relapse of neurotransmitter from into the synapse. And it does that by interfering with several molecules displayed on the graph, which is actually a graph for botulinum toxin, but the mechanism is more or less the same. And basically what happens is that in the neuron there are vesicles containing high quantities of neurotransmitter, and in order for the neurotransmitter to be released, these vesicles have diffusion to fuse and then release the neurotransmitter into the synapse. And the toxin interferes with assembly and functioning of the snare complex in such a way that diffusion cannot occur. And this binding is irreversible, and this means that basically the effect of tetanus toxin can only ultimately be overcome by providing new external terminal ends. And basically, by understanding this pathophysiology, kind of the mechanism the principles of management become apparent. Because the first thing we want to obviously do is to block further toxin release, because while Clostridium is still active in the wound site, more toxin can be produced and taken up by that exon. So that's why it's a cornerstone of management to perform adequate surgical debridement, as was done in this case when the disease process was finally recognized and a wound was actually found. In addition to adequate surgical debridement, antibiotics should also be given as recommended by guidelines. In the meantime, toxin that is in the process of migrating from the wound site into the spinal cord is still unbound and can be neutralized. And this is where tetanus antitoxin comes in. Antitoxin comes in several formulations, equine or human origin. It can be it's usually administered intramuscularly, but in some settings also intrathecally. And in countries with very low incidence of tetanus, where antitoxin is not available, human IV immunoglobulin is sometimes used. And then thirdly, what's very important is to give lots of supportive care, which is mainly addressed, focusing on addressing the effect of toxin that's already bound. And that's by giving neuromuscular blockade and benzodiazepines to avoid muscle spasms, minimizing stimuli, negating the effect of autonomic dysfunction, and by giving respiratory support, which sometimes is given for a long term. For this talk, I want to talk about the treatment protocols for tetanus antitoxin, as there are several discussions about which formulations are best and how these formulations should be used. And the article that I'll discuss is an RCT that was published just last month in the Lancet Global Health, performed at the Hospital for Tropical Diseases at Ho Chi Minh City in Vietnam, which has a large ICU setting. There is a specialist referral facility for tetanus in the south of Vietnam. This was a single center RCT with a 2x2 factorial design that I'll get into. And in this hospital, their standard of care is to give equine IM antitoxin only. The study enrolled patients above 16 years of age with tetanus diagnosed on clinical grounds, and patients were excluded if they were already mechanically ventilated at baseline. And I'll get into that later, but the primary outcome was the need for mechanical ventilation. That's why they did that. So the two interventions that they tested, intervention one was intrathecal antitoxin, and that was compared with the sham procedure that was done completely double-blinded, very impressive, and it was performed in such a way to minimize stimuli that might exacerbate spasm activity. And intervention two was basically to compare equine antitoxin with human antitoxin at what was thought to be equivalent doses for the two. And as said, the primary outcome for the trial was the need for mechanical ventilation. So these are the baseline characteristics of the trial. I'm sorry for the small fonts, but basically 603 patients were assessed for eligibility. Many patients were excluded. 200 were excluded because they did not meet the inclusion criteria. And it is not specified in how many cases, but I believe that in many cases, patients were not eligible because they were already receiving ventilation. 272 patients were randomly assigned to the intrathecal intervention, so intrathecal IM versus sham. And then a lower amount of 218 patients were assigned to either one of the intramuscular interventions, equine versus human. The reason that that number is lower is because some patients had already received IM antitoxin at a referring hospital site. I won't go in depth into the baseline table, but basically here it is for reference. When we look at the outcomes, then basically this is a neutral trial. In the graph, the primary outcome is displayed in the intention to treat population, which is the specified primary method of analysis. MV stands for mechanical ventilation, and in the highlighted box in red, you can see that the first comparison, namely intrathecal treatment versus sham procedure, in patients undergoing a sham intrathecal procedure, 50% needed mechanical ventilation, and in patients receiving intrathecal antitoxin, 43% required mechanical ventilation, for an absolute difference of 7%. This difference was not statistically significant, with a confidence interval of the risk ratio crossing the line. This is not showing that per protocol analysis, the results were the same. If we look at the second comparison, so for intramuscular treatments, equine antitoxin versus human antitoxin, for patients receiving equine antitoxin, 44% require mechanical ventilation, and for patients receiving human antitoxin, this is 45%, which was again neutral. And authors also note that in an extensive analysis of secondary outcomes, no significant differences of either of the randomizations was encountered for autonomic dysfunction, the requirement or dosage of neuromuscular blockade or benzodiazepines, deaths, or any of the side effects of treatments. The authors did note that there were several interactions between the two randomizations. Patients who received IM equine antitoxin prior to referral, if these patients underwent intrathecal treatment, that resulted in a higher risk of mechanical ventilation. An adequate explanation for this is not really given. It was really also very unclear to the authors as to what happened. But this significance was actually lost in the per-protocol analysis. So it remains that this could be a statistical anomaly and the result is included in the proportion. The results of this study are in striking conflict with an old meta-analysis that was published in 2006 that looked at 12 studies performed in the 1980s and 1990s mainly into the comparison between intrathecal and IM antitoxin. This meta-analysis of 12 studies basically concluded that intrathecal antitoxin holds benefit over intramuscular antitoxin. And the authors of the study I just discussed actually also mentioned this meta-analysis and report several design flaws in these studies, notably the lack of blinding. The other striking finding is that the mortality rate in this meta-analysis was 55% in the control group. And in the study performed at the Ho Chi Minh Hospital, mortality rate was only 4%, which is also a testimony to their basically great standard of care in ICU facility. So as take-home messages, I think firstly, as was apparent from the case, clinicians should be aware of the clinical signs and symptoms of tetanus, because even though this is an infrequent diagnosis, it does still occur, can be mistaken for something else. The exposure risk is not always evident at the first physical exam and may not be reported by the patient. Intramuscular equine and human tetanus antitoxins are equivalent in terms of affecting side effects in accordance with the recent RCT I discussed. And there may still be a survival benefit from equal antitoxin, but this has only been shown in certain settings with high overall mortality and in low quality studies. I'd like to end by giving us our references for the clinical case and the studies discussed. And thanks for your attention.
Fantastic. Thanks very much, Lucas and Thomas, for the case. If you can stop sharing the screen, and we'll take questions. Lucas, in your reading, I mean, did you continue your reading and look at availability of the equine product? Because, I mean, what's so difficult is often to get hold of antitoxin, human antitoxin, quickly enough. And the other question relates around just IVIG, the role if you can't get specific antitoxin.
Thanks, Prof. Yeah, I think that the availability question is what drove the primary randomization in the trial between human and equine antitoxin. The study site actually notes that they moved to equine antitoxin as the primary go-to option because of shortage of human antitoxin, from what I could read. And I'm not sure, but I think this might be differential between settings. I don't know. I haven't really read into what the cost differences are between the two treatments. What I did notice that there are actually no real studies that I could find comparing IVIG with specific antitoxin. So I think antitoxin is preferred on the basis of the available evidence.
Yeah, and I may have missed it, but did you mention the vaccination series at all?
I couldn't find, I haven't looked adequately in this trial that was reported. I didn't really focus on that. I'm sorry, I'll have to look into the trial to see if I can still find that data. Sean has a question here as well.
Yeah.
Thanks,
Lucas. So you can imagine the three potential disadvantages of equine. One is like access, getting, could be maybe access better. One is efficacy. The trial address that. I mean, the third one, which is a potential disadvantage, is anaphylaxis. Was there any signal of that? Did it occur more frequently? Did it occur at all in the trial?
So I'll have to check back with you with the absolute numbers of anaphylaxis. I think the reported side effect numbers between the equine and human randomization were completely equivalent. I think they were both at 15%. But yeah, I can circulate the exact numbers later.
Okay, Graham, I'm not sure you've been to visit this unit. I don't know if you'd like to say anything. One of the concerns, of course, is why. I mean, obviously, it has a mortality, but why this boy died. And the ICU in C27 is fantastic, but it's not the darkest, quietest place around. And there's always a concern that the high overstimulation might have played a role. Graham, I'm not sure, having visited in Vietnam, whether you wanted to make any comment.
Yeah, I mean, it didn't strike me that they, were able to provide that very low stimulation environment in terms of light, as you've been prescribed. And so, I think that they clearly have a lot of experience in managing these patients, but there's still, substantial mortality there. I don't have the figures. But it's not as if they're nursing patients in the dark in that setting. And yeah, I don't have further insights. I've seen very few of these cases other than that visit. And we just say that, I think it is in reality very difficult in any ICU to